Morning, everyone. Thank you very much. So yes, I work for Public Health England as well. I'm part of their Southwest Centre, so I work on a regional basis. So whereas Kazim is part of the national team, works nationally, he's the grand fromage, the big cheese, citizen camembert, if you like. I work on a regional basis, which makes me a mini cheese, sort of like a baby bell, probably. And to answer Kazim's earlier question, just in case you were wondering, I've been in tobacco control for 16 years. In November, it'll be 17 years. So I started when I was 12. Right, let's get into it. With that experience in tobacco control and with my portfolio lead as the tobacco lead in the health and wellbeing team in PHE Southwest, I have been involved in some of the projects across the region looking at the implementation of smoke-free policy in mental health settings and also wider, any setting really. And I get asked a couple of questions, quite a lot. First question is, can you tell me or show me somebody else that's gone through smoke-free policy and put it in place and made it work? This will answer that question, because what I'm going to present to you today. The second question that I get when I'm stood up in front of steering groups, and I've had the pleasure of working with a whole number of smoke-free steering groups across the Southwest, is what should we be doing? I understand we need to write policy, we've got signage, we've done a bit of training, but I need to know what other kind of things can we do to help the implementation of smoke-free policy. And so what this presentation will do is frame some of those actions that people can take. And the last thing I'll mention before I get into it is the reason the organisers today have asked me to present this is because it's valid when you're in the planning stage, usually 18 months to 2 years before you go smoke-free. It's also valid in the implementation phase, which is when you're actually making it work. And as I see it, the commitments that the Mental Health Task Force have put us to, and also the 5-year forward view, which is to be smoke-free in 2018 for mental health settings, acute trusts be smoke-free 2020, that is the implementation phase. The commitment is to have implemented it by then. But this is also valid in the post-implementation phase, because this is an approach, and if we're going to make this work, it's got to be an approach of continuous improvement. We're constantly looking at what have we done, how can we improve it, how can we improve compliance with smoke-free policy? Because this is a culture change, and it's not going to be something you can just write a plan, implement it, and then walk away. I suggest probably 2-3 years afterwards, that's the time when we can start to ease our foot off the pedal, because the cultures will have moved on, and we will look back and we'll go, how did we ever have smoking on hospital grounds? But we're not there yet. So this is a bit of research that I did. I was looking specifically at social marketing, which I'll explain a little bit more about in a second, and does it benefit the implementation of smoke-free policy in a mental health setting? But the truth is, it could be any setting. This was just a particular setting that I was interested in, and it's a qualitative case study of Langton Hospital, looking at it through a social marketing lens. And what Kazim has done beautifully has told us all about the policy and the guidance and all of the things that are out there. What I'm going to start to do is to tell you about the added extra. So once you've read the guidance and you've followed the rules, what's the human aspect of this? What is the how? We know what to do. How do we go about doing it? Again, I'm not going to talk too long about this because Kazim's covered it beautifully, but I just want to highlight the British Thoracic Society Smoking Cessation Audit Report, which was basically looking at a number of trusts across the country, and a few key points. Only 1 in 16 institutions completely enforce smoke-free grounds. Only 1 in 13 patients who smoke were referred to a hospital or community-based smoking cessation service. More than 1 in 4 patients were not asked if they smoked. Nearly 3 out of 4 smokers were not asked if they would like to quit smoking. We're not asking the question where, when we get the feedback, I'm a smoker, we're not asking them or advising, would you like to stop? And then we're not getting them into proper treatment. And Kazim's graphic of defining what a smoke-free NHS looks like hopes to tick all of those off and cover those. And again, Kazim's covered all the recommendations, but this is despite NICE guidance, PHE guidance, Mental Health Task Force, Sequins, which are all levers and driving us to become smoke-free. So let me talk about my study. The aim of my study was to find out, does social marketing enhance the implementation of smoke-free policy in a local mental health setting? And so I had two questions, which I was going to do when I went into this place, which is Langdon Hospital in Devon. Is there evidence of social marketing practice being used to manage the barriers and facilitators? And does the application of social marketing principles benefit the adoption? Now, of course, they didn't know that they were doing social marketing. They were just going about their business trying to put in a smoke-free policy. Again, one other little side note, which I would just say, is that if you have the pleasure of doing a literature review on smoke-free policy in mental health settings, which I have done for you, you will find it awash with these types of things which come up time and time again, and I'm sure they will resonate with you if you're involved any way of putting policy in place. Smoking staff are less likely to support smoke-free policy. Smoking patients are less likely to support it. If you don't do consultation, it doesn't work. Poor commitment from management, perceived lack of ability to enforce it, poor guidance and training. A belief by staff that smoke-free policy will have adverse effect on patients, lead to abusive patients, may damage carer-patient relationships. The literature all highlights these as common things which come up when you try to put smoke-free policy in place in a mental health setting. There are some facilitating factors as well, but also what the literature comes out and says is typically smoke-free policy does have a positive effect on smoking prevalence. Fears tend not to be realised. Smoke-free policy ultimately garners support from staff and patients, and it is possible to do it without serious negative consequences. This is my favourite quote from the literature that I read, because it's really summarised the spirit of what I'm going to kind of package for you today, which is the adverse effects associated with the policy in mental health settings can be ascribed to the way in which the policy was implemented. And that's the first slide, the added extra. It's the way in which we go about it, which is the key. So, social marketing. For those of you who may not be completely clued up with social marketing, this is a very quick overview, and this is just one person's view of what social marketing is, but these are Andreassen's benchmark, who's a scholar in social marketing. And according to Andreassen, if you want to do good social marketing, you need to have a very clear behavior change. You need to be specific on what it is you want to do, and you need to be able to measure it. You need to be doing audience research. That is to say, you need to walk in the shoes of the people you're trying to change their behavior of and understand their world in order to help facilitate a change. You should segment your audience, which means don't be all things to everyone. Don't try and change the whole world. Think about who is your target audience. Is it people who smoke, who are resistant to the policy? They're probably an important segment, not just staff or carers or service users. There should be an exchange in place, which is to say, if we're going to ask you to change something in your behavior, we need to replace it with something else. There needs to be a benefit or some kind of exchange. And of course, e-cigarettes fit very neatly in that. Marketing mix, I think we're probably comfortable with, which is about promotion and the 4 Ps, product, price, place. We're very good at promoting smoke-free policy. And then competition. You should think about what's acting in competition to your desired behavior change and address it. So if you're doing good social marketing, you're doing these 6 things. And it was those 6 things that I was looking at and the filter that I was looking at when I went into Langdon Hospital, which is a 111-acre site, provides forensic mental health services for men with mental health needs who have had contact with the legal system. And this is their kind of setup. They've got 5 units. 1 unit is medium secure, 2 low secure units, and 2 open units. And the medium secure units has 4 different wards. Key managers and people within the organisation, I was just trying to find out, how did you get on? How did you go about it? And I did my interviews, and I was looking for those kind of key themes. A number of themes came back, and what I've tried to do is rate them as very limited, some, strong, or very strong. And so I will very quickly go through those. So, behaviour change. This one's a bit of an obvious one, okay? This is pretty basic. It was pretty clear what the behaviour change was, and it was quite measurable. It was well communicated, had concrete timeframes, and so there was strong evidence when I looked at my interviews of people being crystal clear on what the behaviour change is. There is some discussion about whether it's a voluntary behaviour change and also whether behaviour is about stopping smoking or rather, probably a more strategic way to frame it is compliance with the policy. You want people to behave in line with the policy. You don't necessarily want them to become smoke-free instantaneously. You want them to comply with the policy. The policy goal is clear. The whole site went smoke-free. They had a core group. They did have some forced starts, but ultimately smoke-free policy became the accepted norm. There are quotes which support the claims I'm making around the key elements that I'm putting forward, but I won't read through them. This slide set will be shared, so you can go back and have a look at it if you want. I might just pick out a couple. Now we're getting into something really important, okay? This is what makes the difference. Audience research. When I did my interviews, there was lots of feedback that I got from managers that there were significant levels of formative research, even post-implementation, a culture of open conversations. There was definitely an approach by the management, the change agents, to make sure that they were walking a mile in the shoes of the people that they were trying to influence. Participants were unanimous in emphasizing the importance of having open conversations to address the anxieties of patients and staff. Participants gave extensive accounts of activities related to facilitating open discussions and repeatedly emphasized that staff participation, creating informal spaces to ask questions, voice concerns, collaboratively design solutions, really important, collaboratively designed solutions. Many of the participants stated that this was a fundamental practice for realizing success. So in this case study, they had a smoke-free steering group, but they relied on ward meetings, ward manager meetings, patient forums, governance board meetings, patient councils, constantly raising the issue as a standard agenda item. Right, the smoke-free policy is coming into place. How are people feeling about it? What are your issues? Now, going back to the literature and people's experiences at smoke-free groups is we've got all of this fear and anxiety. Our staff are really worried. If we put policy into place, we're going to get abusive patients. We're going to have lots of difficulties. All they can see is the problems. This is the solution. I could tell them about the literature, but that's not going to wash. What will wash is if you give them time and space to explore it, work with it, and chat it through. And eventually, they will start to work out and design their own solutions. Let me be crystal clear. What's up for debate here is how we go about going smoke-free policy, not whether smoke-free policy is going to happen or not. That's a given. It's the manner in which we're going to do it in our context and our organization. So we started talking to everybody about going smoke-free, probably about a year before we actually started going smoke-free. So we talked about it in all our team meetings. We talked about it in supervision with the staff. We talked about it in patient forums. One of our patients came to the smoke-free meetings with me, which was fantastic. So it was out there. There was no confusion about it. It was out there, and because it was out there, all the questions and concerns and worries that people had were sort of dealt with before we actually started the process of going smoke-free. You're absolutely off to a winner if you're leaving on that foot. If you're trying to implement smoke-free policy when staff in particular are having a lot of resistance to it, then that's going to be a lot more difficult. In terms of the patients, giving them a little bit of space to do this, they feel in control. They feel that they've got a choice, and they feel that they are being listened to, and they get invited to the governance board meeting once a month to say their piece as well. Collaborative design of solutions. And I'll come on to that in a minute. I'll reflect on that. Third, benchmark, segmentation. Very quickly, very little evidence of applied segmentation, other than we talk to patients, and we put them as a group, carers, we put them as a group, and staff, we put them as a group. Actually, you could probably do a little better in segmenting them even more. Patients who smoke, patients who don't smoke, patients who smoke who are in support of the policy, patients who smoke who aren't in support of the policy. All of a sudden, you've got a neater, tidier target audience, and you will start to see, well, those are the most important. We need to adjust our communication strategy to help those people along this journey more than anybody else, rather than just trying to be all things to all people. So, we could do more on segmentation, and there's loads in social marketing literature which will help with that. Next benchmark, exchange. This is where Langdon Hospital, in particular in my opinion, absolutely excelled. They put huge amounts of effort into thinking, what can we give in exchange? They had structured, planned activities offered, and I believe, if I'm right in saying, you can talk to Jane about what that was exactly, because Jane's very much involved in that part. What are the environmental and other intangible factors considered? They had NRT offered without limits. Pharmacists would sit down with patients and help them navigate through the NRT to deal with nicotine withdrawal. They raised and commented to patients that actually, if you do stop smoking, you have to take less pills. Okay, you get clozapine reduction. That's a benefit. That's an exchange. You're going to stop smoking, but look, there's a benefit. It's about highlighting all of those. And then, of course, e-cigarettes. It's no good forcing somebody to do something if you've not got nothing to replace it with. So, here's an example of planned activities and events which were offered, in this case, for smoke-free policy implementation. Now, I'm not suggesting that in your organization or in your context, if you give people remote control cars, that that's going to be the solution to smoke-free policy, although it might do, actually. What I'm saying is, have a think about what kind of things, potentially activities or other things you can offer in exchange of the policy. Clearly, the obvious ones are, we give smoking cessation support. We give staff time to go and stop smoking. We make sure NRT is available and it's easy to get hold of. You can vape in this place. There's vaporizers available in the shop which you can buy. Those are all things which you stack up and say, yes, I understand all the concerns about smoke-free policy, but the evidence is clear, we've got to go smoke-free, but look at all the other things we offer in exchange. Intangible factors and environment, NRT I've mentioned, clozapine I've mentioned, e-cigarettes. This is just, again, to reflect on this earlier point. Patients had an option to question and be involved, and we wanted to work with them, and that's why we introduced e-cigarettes, because a few of the patients on the board said, why can't we use e-cigarettes? And we thought, we didn't think we could use them. Back in the day when these guys were going smoke-free, our confidence behind e-cigarettes is nowhere near what it is now. They were at the cutting edge, really, and they took the brave decision when they looked at the evidence and got expert opinion in, say, okay, we can do e-cigarettes. But just imagine the situation. Patients are dealing with this thing that's coming their way. They're being involved in the design of the solution. They put forward a point. Can we use e-cigarettes, please? The management go, no, I don't think you can. But, all right, we'll go and think about it. They go away, think about it, and say, yeah, okay, we'll meet you on this. They were genuinely involved in the decision-making process, and they could see changes happening because of the feedback that they were giving. That is when you start to get implementation of policy really working. Decision-making power is another one. We would talk about which smoking breaks would be good for you, which would help you, for which for us to take out. This, by the way, is in the context of regular smoking breaks through the day and just weaning them down, taking them out, but the patients got to choose. So they had control of power, what was happening to them. Very powerful. The marketing mix, not going to spend much on this, but basically to say there's high levels of promotion. We're very good at communicating. In this case, they had a countdown clock and agenda items and posters and leaflets and videos and things like that. Extensive trading of staff. And looking at the 4 Ps, promotion, product, price, and place, and also policy and people, I think possibly we concentrate too much on promotion, and we could do well to look at the other Ps in terms of what benefits they could offer us. The last one is competition. Again, very strong. They looked at what the fears, anxieties, resistance of staff patients, and then they decided to think, okay, well, what are our strategies for dealing with this? What kind of information do we need to give people? We will prepare in advance for that challenge and that competition and then diffuse it. They had a phased approach, took their higher secure units smoke-free first. They looked at environmental factors, anticipated and prepared for a legal challenge. At the time, I did the interviews. There was one in operation, but I think that's come to a conclusion and was positive in favor of smoke-free policy. So yeah, I think I've covered that. E-cigarette introduction, of course, diffuses something which works in opposition to the policy. They moderated access to tobacco, phased approach to implementation. They prioritized the secure unit, environmental factors, dealing with nicotine withdrawal, and also preparing for legal challenge. I think I covered those. I always get asked about evaluation. How did they evaluate it? Now, these guys didn't evaluate it in the terms of it's going to be published in a journal. They were just doing what came intuitive to them in terms of what they could measure. But they did measure heart rate, blood pressure, peak flow, lung capacity bits as well, which is part of a wider project they were doing. Medication prescriptions and costs. These two are the most important one. Structured reporting of smoking tobacco-related incidences and structured reporting of violence and aggression-related incidences, which is all part of their recording bits and pieces. And so this was after they'd gone smoke-free. So we've got in our trust a incident reporting system. There's a flag for, is this a smoke-free incident or smoking incident? So then I get copies of those so we could monitor it, and quite clearly we've not had many. Yeah, so when we had more smoking incidents before we went smoke-free, which is counterintuitive, isn't it? But it also is completely in line with all the literature. What I showed you in the literature review, fears are not realised, this is typical. There's nobody smoking, there's no option to smoke, so it's kind of a zero, always. There were other factors. I'm not saying social marketing solved them all, but they talked about having the right type of managers, making sure there was senior level buy-in, external factors were driving the change, the NHS Trust took ownership, the intrinsic motivation of the organisation, and again, this issue around this is an enforced policy, not a behaviour change. So it doesn't quite fit with social marketing. So these guys didn't know they were doing social marketing. I was looking at it through the lens, but I answered my question. Is there evidence of it happening? Yes. Does it help? Yes, it does. Or my study would say, yeah, that kind of approach does help the implementation of smoke-free policy. The hospital was able to demonstrate successful implementation. They experienced all of the expected and typical barriers highlighted in the literature. Practice was aligned with the guidance and recommendations, and this study suggests that the management went further than the recognised initiative examined through a social marketing lens. The benchmarks are useful. Participants didn't know that they were doing social marketing, but they were. Behavioural objective is around policy compliance, we would argue. There were several other factors that participants felt strongly helped with the policy, and it's not suggesting that social marketing is a panacea for policy in mental health settings, but there is evidence that it validates social marketing as being of benefit. There were, of course, lots of limitations. I'll let you read those later. Those are some of the conclusions I get, which I think I've covered already. And so these are the recommendations which came out the back of it. So this is my last 3 slides. How am I doing for time? 5 minutes, perfect. These are the recommendations. Utilise a social marketing approach when designing plans, and I'm actually going to extend that to designing, implementing, and post-implementation smoke-free policy in a mental health setting. Any setting. Doesn't matter if it's a mental health setting. Any healthcare setting. Use the social marketing benchmarks as a framework to develop your policy. Define clear behavioural objectives in terms of policy compliance. It's not about stopping people smoking. It's about how do we help people comply with policy. Conduct formative research. Make sure you walk a mile in people's shoes. Understand the audience that are going to be affected by this change. Exploit conventional social marketing segmentation techniques. If you type into Google social marketing segmentation, you'll get tools upon tools of how to take you through a thinking process of starting with a really wide audience, then segmenting it down into something meaningful, and then you deciding, well, which ones are our priorities, who are we going to talk to? Because you will adjust your strategy once you know who your priority key opinion leaders or your change agents are. Apply a balanced marketing mix, which just goes above and beyond promotion. I think I've missed that one out, isn't there? Invest in programs to offer service users and staff something beneficial in exchange. What's becoming more important to me, more clear to me with my experience across the Southwest is e-cigarettes and vaporizing is a very important aspect of this. But it's not just about that. It's about the service, about NRT. It's about all the other kind of things which we can offer. Anticipate factors which may act in opposition and start to put strategies ahead of that in terms of how you can diffuse it. So this is my last slide. And what I've tried to do here is answer that question that smoke-free steering groups give to me, which is, okay, what should we do? And I have got steering groups which plan their agenda on this very set of things. This point in the top right is most important. Compliance orientation as opposed to enforcement. So the trap that some smoke-free steering groups step into is, okay, well, we've got the policy, we've got the signs up, we've got bits and pieces going on. How do we enforce it? Do we employ a security guard to walk around and tell people not to smoke on site? Do we train our staff and get them to tell them? Now, enforcement is part of the answer, but if you focus on that, you're going to fail, because what you're going to get is effectively a spirit where somewhere on our highs decided a policy and we're projecting the policy down to people. Actually, what you'll find is when you implement the policy, your smoking incidences or your rates of smoking will drop because you've changed the environment. But will there still be smokers around? Will smokers breach the policy? They probably will. And I've got examples of hospitals where smoking policy is being breached. Is it better than it was before? Yes. So you come back to this. compliance orientation, and quality improvement, continuous quality improvement. What's the next thing we can do to improve the quality of what we've got on offer to improve compliance with the policy? Then you're onto a much bigger, better strategy and a way of working than how can we force people to stop smoking on our hospital and stay the right side of the white line if they're going to have a cigarette. And so going back to my example of smoking steering groups who use this as an agenda, these are the things you should be putting your resources into, in my opinion, if you look at it through a social marketing lens. Communications. So top of the agenda, right, what are the comms? What are we communicating to staff? Who are we communicating to do? How are we doing it? What's the communication plan about what we're planning and what we're doing? How are we training people and what training is on offer? What kind of things have we got in exchange? Are we dealing with our vaping policy? Have we got one written? What about treatment pathways and the access to nicotine replacement therapy and dealing with withdrawal and people who come into our organisation? What activities have we got on offer? What's the price? What's the cost of somebody having to go smoke-free, and how can we minimise that cost to them? Audience research. What are we doing in terms of understanding our audience? Can we use our networks, our already established meetings? Who can we engage with? Who can we segment and who should we be targeting? And who can we collaborate with to get genuine collaboration to design solutions? And how can we deal with the competition? And in the middle of all of those things, both quantitative and qualitative, what kind of things can we measure? Because as you go along this journey, it's a very important, very powerful thing to do. When you get challenged, and you will, and I get challenged on the radio, and journalists get in my face and say, you know, you say you've got a smoke-free site here, but I've just seen someone standing underneath a sign smoking. Well, actually, if you look at the data, where it used to be and where we are now is much better, and we've got all this other stuff on offer in exchange, and we're going in the right direction. So making sure that you're measuring parts of it's very important. I think I've run out of time, so I will leave it there. Hopefully I was on time. Thank you.